Hello, everyone, and welcome to another WEDI CMS 0057 implementation update, this one focusing on provider and EHR perspectives. It's my pleasure to introduce the Executive Director of WEDI, Robert Tennant.
Thank you, Michael. Let me add my welcome to this program. If you joined it, it's because you know that this is one of the most transformational final rules that we've seen from CMS in many years. So we've got a wonderful group of speakers that I'll walk through in a minute. But for those that perhaps aren't as familiar with WEDI as others, I wanted to tell you a little about our organization. We were formed back in 1991 by Dr. Lewis Sullivan, who was a practicing physician who was appointed by then President George Walker Herbert Bush. So it's going back a few years. And he brought together some of the leaders in healthcare, trying to identify some opportunities to streamline data exchange, in particular between providers and health plans. And so through that group, he created what he called the Working Group for Electronic Data Interchange. They developed two reports which were then folded into legislative language, which became what we all know as HIPAA. So, in fact, WEDI was named in HIPAA as a former advisor to the Secretary of HHS. We have a very strong relationship with the federal government. In fact, ASTP, ONC, and CMS both serve on our board of directors. So we also have a good relationship with the Office for Civil Rights on the privacy and security side. We are a multi-stakeholder membership organizations representing health plans, providers, vendors, standards development organizations, both state and federal government entities. And one of the areas that we're growing in is patient advocates. We have 18 health IT work groups, sub-work groups, and task groups that I'll talk about in a second. But our role is simple. That is to convene the industry, to collaborate between stakeholder groups, to educate like we're doing today, and to influence the direction of health IT policy. So I mentioned our work groups. That is the heart and soul of WEDI. It's how we do the vast majority of our work. And we have work groups in all kinds of areas, all of the major HIPAA transactions, but also things like payment models. So we have the dental sub work group that Arna is the chair of, and she is a speaker today. We also have one on prior authorization. So if this is an issue that is important to you, then I would encourage you to get involved with WEDI and become part of the prior authorization sub work group. We also have a brand new group that is just starting, and that is called the Patient Experience Work Group. So part of the federal rule we're going to discuss today is making sure patients have better access to their health information and get decisions on prior authorizations faster. So that will be a work group that will be looking at these and other issues. So you can see from today's agenda, once we get through our welcome, we have a blue ribbon panel of experts led by our good friend Mark Scrimshire from Onyx Health. We'll then be able to talk to some experts from the EHR world, including Greg Legros, Hans Beitendick, and Ryan Bowicek. We'll then switch gears and we'll invite my good friend, Dr. Stephen Waldron from the American Academy of Family Physicians, and he'll talk about his work with the Da Vinci Clinical Advisory Panel. Then we have a panel of provider experts, including Michael Marchant, Andrea Preisler, Heather McComas, Arna Meyer, Anna Taylor, and Samara Singh. So we're very excited. And it is going to be led by our own chair-elect, Danny Brennan, from the Massachusetts Health Data Consortium. I will remind folks, one of the roles that WEDI plays in the industry is to gauge how implementation of these final rules are going. And so early in the year, we conducted a survey. We got a great response rate, and it suggested that a lot of stakeholders, both providers and health plans, weren't quite ready for this transition to APIs. So if you're interested to review the results of that survey, that is available at wedi.org. And I'll mention that we have a few programs coming up from WEDI, including one specific to 0057 and digitizing health policies, sponsored by our friends at Cohere Health. That is taking place on June 26th. And I will remind you that we'll be meeting in person in Chicago, August 5 and 6, to talk about both the CMS 0057 final rule, and then on the second day, we'll be focused on the potential new EDI X12 transactions known as the 8060 version, and that will highlight an opportunity to speak directly to CMS. They will be in Chicago to conduct a listening session on this new transaction set. I will remind you, we try to make these programs interactive. We have really a phenomenal group of speakers that you want to take full advantage of. So ask your questions by using the chat feature in the Zoom toolbar. And slides and the recording of the event will be emailed to all registrants following the event. And with that, I'm delighted to introduce Mark Scrimshire, who is Chief Interoperability Officer for Onyx Health, to give us a technical walkthrough of this very complex rule. Welcome, Mark.
Thanks, Rob. It's great to be here. Let me see if I can replace current share. Let me pull up my presentation.
Mark, your audio on your microphone is still choppy.
Let me just try and switch that. Let me first deal with the audio. So hopefully you're seeing my screen. And I'm hoping my audio is just my voice being a pain today.
And your
switching over.
Slides are up. They look great.
Great. And let me just finish switching over here. How's that, Michael? Is the audio any better?
Yep, much improved.
Okay, fine. Give my AirPods a rest. Okay, folks, thanks very much for tuning in. I'm going to try to give you an overview of the CMS 0057 or prior authorization rule, and do it more from the perspective of you as providers. So a little bit about me, just so you know where I'm coming from. As Rob said, I'm Chief Interoperability and Innovation Officer at Onyx. I'm also the author and co-chair lead of Da Vinci Payer Data Exchange, the implementation guide. That also touches on PlanNet and Formulary, which are parts of the original CMS 9115 rule. I'm also co-chair of HL7 Financial Management, and I'm a board member of the Fire Business Alliance, so I can wear many hats. Let's try and break down the rule from your perspective as providers. Well, first thing, the rule itself is really about 7 to 10 times more complex for payers than the original CMS 9115 patient access API regulation. it has something like 50 plus requirements. One of those is potentially for you. So what's really this rule trying to do? It's really trying to drive greater transparency by payers. So that's having standardized API. So really trying to reduce the confusion of how do I get an answer from all of the different payers I have to interact with. When it comes to prior authorization, there will also be other APIs that you can tap into. Another important thing that will happen will be metrics. So payers will have to publish metrics about the patient access API to CMS, but more importantly, maybe from your perspective, is prior authorization information is going to have to be put onto their public website. And another thing that CMS learned from the original rule is really it's important to have education, both for patients and for you as providers, to understand really the potential benefits of these APIs. So all of that goes into those 50 odd requirements that are in there. And so there are really, from the payer's perspective, there are 4 pillars to this. There's the patient access API. It is being expanded and updated. There's going to be a payer-to-payer bulk API. So when members move from one plan to another, they'll be able to effectively pull their data forward if they choose to. And then the 2 things that are really should be of interest to you, provider access as a bulk API. You'll be able to query the health plan about the members that are attributed to you so that you can maybe understand a greater view of their care journey that they're on. And then the big piece that everybody's been focusing on, prior authorization. So a standardized API for getting an answer about, do I need a prior auth? And if I do, what data do I need to give the payer in order to get an answer? So who's impacted? So just, you know, who are those payers out there that potentially are going to have to implement this? Medicare Advantage plans. So there's about, I think around about 1,000 of them in the US. Medicaid agencies. So if patients are on Medicaid, the Medicaid state agencies are needing to implement that. And we've certainly seen in really the last 6 months, a real increase in interest in actually implementing these capabilities. And then there are also the qualified health plans that are on the federal exchanges. So that's not every state is covered there. It's those that where the qualified health plans are actually handled by the central, basically Medicare.gov federal exchange. Another wrinkle there that we're seeing increasingly is if you're in California as a payer or in Tennessee, there are regulations at the state level that are basically pointing to the CMS regulations and saying, if you're regulated in our state, you need to follow those rules. So we're going to see the adoption of these APIs across more than just the regulated plans. And we expect that to also increase. I think recently, just a week or so ago, we saw Nebraska put out additional regulations around prior authorization. So what we're also seeing, and I'll put my implementer hat on for a minute, is we're seeing a lot of plans that have these regulated plans, so Medicare Advantage primarily, are looking at how they are going to implement these APIs, particularly prior authorization. It's pretty big and complex. But what is interesting is that, and this maybe goes to your point, Robert, that maybe plans aren't quite ready, but they're definitely gearing up right now to get into working out how they're going to comply with these rules. But they're also thinking ahead about how am I going to expand this potentially to all lines of business. And that's good for you as a provider, because why should you have to know whether someone's on a Medicare Advantage plan or a commercial plan as to whether you can go and ask a plan in your workflow, whether you need a prior auth or not? So ultimately, I think this is going to spread across all of the plans. And we're seeing organizations like the Blue Cross Blue Shield Association starting to talk with their affiliates about applying these, particularly the prior authorization API, across all the lines of business. So, timelines, what are we looking at? We can look back in history at CMS 9115, the Patient Access API, and that went into effect in July 2021. The prior authorization rule, the CMS 0057, it took quite a while to land. It initially came out in December 2022. It went through comment periods. It went into a period of CMS trying to work out exactly what they were going to do to finalize the rule. And then last year in January, they actually published that final rule, and it hit the Federal Register sometime in early February. And there are a couple of timeframes there that are in that rule. One is that reporting of prior authorization metrics are going to be necessary by these impacted plans, these regulated plans, by March 31st of 2026. So they are going to have to report on the 2025 calendar year performance of prior auth. So things like how many prior auths required, what codes required a prior auth, what went to appeal, what was actually overturned on appeal. There's a whole set of statistics that are going to be covered, including what is handled as standard prior auths and what are handled as expedited. And the rule also shortens the timeframes for those prior auths. So there's potential impacts for you that have a positive impact on patient care. So 2026 is an important part. We're also going to see EHRs, basically ONC has moved the goalposts on what is in the FHIR community we refer to as US Core. It's going from providing coverage for US CDI version 1 to version 3. So you will now start to see probably things like references to US Core 6.1. And so it's really just an expansion of the content that is available as structured data that will be able to go out through the FHIR APIs that certified health IT products, like most of the EMRs, will have to generate. So payers are going to be starting to receive that data as well, and need to gear up to also be able to publish that data, likewise through the various APIs. And then in January 2027, plans have to implement these APIs. So the prior authorization API, the upgraded patient access API, the payer-to-payer, and the provider access APIs. So provider access and payer-to-payer are bulk APIs. So you'll be able to go and get data about all of your attributed members if that's what you want to do. And remember, there's lots of other things happening. We're seeing moves around TEFCA happening in 2026. We're also going to see, I think, other regulations coming out around good faith estimates and so forth. And then also the move that is happening in the NCQA world, where HEDIS is also moving towards a digital format being based on the same FHIR resources that are expected to be used in these APIs covered by this prior authorization rule. So what needs to be delivered and when? We've covered some of this. So payers have these 3 milestones. January 1st, 2026, really being able to handle US Core 6.1 data or US CDI version 3. That will also obviously be an impact potentially for you as providers. The metrics reporting has that deadline of March 31st, 2026. So at least then you will be in a position to go to a public website for a payer and find out what codes require a prior auth. And then those APIs will go live in January of 2027. So amongst those 50 odd requirements in CMS 0057, there is also this minor statement that says that basically MIPS eligible clinicians, hospitals, and critical access hospitals will need to attest yes or no to whether they have used the prior authorization APIs at least once via certified health information technology, basically certified health IT products, your EHR. And so I think what you can expect is over time, as the payers are implementing these APIs, there could be more and more pressure for you to adopt using these prior authorization APIs. And the step of actually getting to be able to do even one attestation for an exchange for one prior auth inquiry means you've got to do some setup to be able to do that for more things. And hopefully, as we get into the panel later on, we'll hear from people like Anna and Samira about the tremendous potential advantages and actual advantages of using these prior authorization APIs. So why should you be interested? Why should you be getting ready for that now? So this is our eye chart. I'm not going to test you on this in detail later, so you'll get this in the email that goes out. But the key thing, top left corner, see the red box. That was the original patient access API. So all of these additional requirements are new in the 0057 regulation, but it really falls into these 4 pillars for payers. An expansion of the patient access API. So your patients come 2027 will be able to get information about their prior authorizations through the patient access API. So if they have a consumer app like from BeWell or Flexper or a number of other candidates out there, they would be able to pull that information into their health record and be able to see what is happening with the APIs, with those prior authorizations. They'll also be able to see things like vision and dental records. So there's much more information potentially at their fingertips. And there's no reason why those apps couldn't actually be able to share that information with you. But I think CMS recognized that not many people have actually used these APIs. It's a bit of a chicken and egg scenario. Yes, they may have been implemented, but have they been promoted? Are the apps out there able to make use of this? And it's been a challenge for many apps to get connected to some of these APIs. So with that in mind, this is why CMS put in these 2 additional bulk APIs. One, the payer-to-payer API. We change our minds as consumers, and particularly in the Medicare Advantage space, we may hop from one plan to another from year to year. Well, why shouldn't our data be able to come forward with us? And so the payer-to-payer API is an opt-in API where patients, members can go and say, yes, go get my information from my prior plan. Here's some of my information, my old coverage card information. See if you can get the match and go and pull that data forward and incorporate it into my record. And so we start to see a longitudinal health record emerging. And that can include the prior authorizations that are currently in effect. The other piece that will be of interest to you, obviously, is the provider access API. So this is designed such that by default, members will be opted in. They have to take an active action to opt out. And so payers will be able to construct attribution lists to say that you as a provider are providing care to this list of members, and you will be able to go and query for basically any of that information that really is available through the patient access API. So their claims, any of the clinical data that the plan may collect from other providers, and the prior authorizations. Now the claims will be there, but they will be without any financial information. So you'll know what happened, when it happened, who did it, but not how much it cost. So, but you will be able to go and pull that information down and incorporate it, whether into population health analytics or to help you close care gaps. It'll be up to you how you want to use that. Then the big pillar the one that everybody is focusing on is prior authorization. So this is where you will be able to go and do a query and find out, do I need a prior auth or not for this procedure? And in theory, get a response back in really just a few seconds. And if the answer is, yes, you do need a prior auth, it's going to then be able to tell you what information do you need to provide so you can pull that together and submit it and then ultimately get the decision back. And that's basically incorporating really 4 implementation guides that the Da Vinci project in HL7 have implemented. And so I'm just going to quickly run through that. The prior authorization API is really constructed of these 4 components. CRD, what's that? Coverage Requirements Discovery. It's basically asking the question or answering the question, do I need a prior auth or not? And so you'll submit a standard set of information, get that response back quickly. Now, if a prior auth is required, it goes to the next step, DTR, or Documents, Templates, and Rules. So in this, it's basically the idea is that the payer will then say, if I'm going to make a decision on this particular code, this request, I need certain information, and they will provide effectively a questionnaire that will basically allow you to submit that information. Now, when this is fully implemented, in theory, what should happen is that there will be a query associated with that questionnaire that would be able to go against your EMR and extract the information that's necessary. So you ultimately only have to fill in the gaps. And so once that is compiled, you'll be able to send that in via what's known as PAS, or Prior Authorization Support. So this defines a way of sending that bundle of data in, having it being reviewed by the plan or their utilization management vendors, getting the result and communicating that back to you as the provider. Now, there will be some situations where the plan may need to ask additional data, and that's where another API is referenced, Clinical Data Exchange. And that's really to ask those one-off questions, maybe because it's a combination of conditions that a patient has, that they want to get other detailed information that's not normal run-of-the-mill for that particular code that's being requested for. But the big advantage of this is if you think about the way that maybe you have to do this today, maybe you have to go to a payer's provider portal and copy and paste a load of information to get an answer. And that varies from another plan. You may have to go and send a fax, or you may have to get on a phone call to be able to confirm whether a prior auth is required, or you may have to go to a website and dig down through hundreds of pages of PDF to try and work out, is a prior auth required? Instead, there would be a single API that you can choose to use. You are not being forced to use this, but basically ask that first question, do I need a prior auth or not? And if I don't, I can get on and immediately book that patient in for service. That's a potentially great improvement in patient care. Think about the number of patients who may not proceed with a surgery or a particular intervention because they left the office because they were waiting for a decision to be made as to whether they could get the treatment or not. So all of this starts to make it simple, and what we're expecting to see, and I hope people like Hans will confirm this, is incorporating that into the EMR in your workflow. So almost transparently, you get some of these answers without having to do a lot of extra work. Okay, so what we expect is that we'll see adoption of these APIs over time and a reduction in the other methods of having to get the answer. So just imagine, I couldn't resist a bit of humor here, that just in case that particular type of prior auth request that is put in just in case, in many cases can be up to 50% of the time, right? Imagine if that unfortunately dies come January 1st, 2027, because now you could know, yes, I need a prior auth, or no, I do not need a prior auth. Think about how much time that would gain you back. think about what that would mean to patient care, in that you can just get on and deal with the patient's condition and try and help them as really you want to do. And I'm hoping that Anna and Samira may, reinforce this. I think existing testing to date is showing that we're seeing a dramatic increase in the number of prior auths that can be processed. And that has a big impact on efficiency as well as patient care. So yeah, think about that. Imagine saying, okay, let's book that procedure right now. And I couldn't resist including here my friend e-patient Dave, one of the premier patient empowerment advocate and evangelist, and Dr. Danny Sands. So in wrapping up, I know we're getting close to time. So there are really 3 APIs that are of interest here: patient access API for your patients, provider access for you, and payer-to-payer bulk API, as these are what I call the access APIs. And remember, the prior authorization information is also going to have to flow into these APIs, so they're going to be available. So imagine you sent a patient to a specialist put in for a prior authorization. Imagine that that's decided, and you could actually pull that information through the provider access API for the members that are attributed to you. So you might know just as quickly as the patient whether that procedure was approved for the specialist. I'm going to just really brush over this in interest of time. The key thing here, prior authorizations are also going to be available to you. Okay, so you'll know what has been approved, what has changed status in the last 12 months for your patients. That'll be available not only in the patient access API, but in the provider access API. You'll be able to pull that information. Obviously, as I said, the claims information will not have the financials. Now, big question that I often get asked is, does that mean as a provider, I'm going to be drinking from the fire hose? And yes, I couldn't resist the pun, right? And the answer really is no, you do not have to if you don't want to. And that's because the payer will control the attribution list. And there is a lot of discussion going on about, well, what about impending treatment relationships? How can that be triggered? And there's thinking about potentially could that come as part of seeing a prior auth happening for a particular provider? And maybe being able to use that as a trigger to say we should allow them to see the rest of their health history. So yes, the payer will create these attribution lists that drive the bulk API, and they can use their own business rules. So you will want to find out how the different payers are going to handle that. Some may be more interactive with you and be prepared to take your attribution lists and submit them, but they also have to take account for members that actually choose to opt out. But then once you've got access potentially to a whole list of members that you can get data on, you can actually construct the query into that API to be as targeted as you want. Do you want to look at a particular period of time? Do you want to look at just certain types of resources? Are you just interested, for example, like the one case I use, if the payer had information from labs on A1C results, is that all you're interested in? Or maybe you're just interested in the prescriptions that have been paid by the plan for the patient, because that indicates that they actually went to the pharmacy and got those drugs. Pretty close indication that they're taking them. So you can be very selective in the information you want to receive. You do not have to take absolutely everything. If you want to, you can. It's your choice. So, quick summary. There's 18 months to go. If you're a MIPS provider, you want to be thinking about getting ready to attest to say that you've been able to use these APIs. And for payers, just appreciate it. It is more complex. They are doing something very complex. But ultimately, I think everybody wants you to be able to use these APIs because they are going to benefit both patients and your own office's efficiency. So with that, I think I'm just over time, so I'm going to stop there. I'm sure Danny will be coming in to keep me under control very shortly, but I'm happy to take questions in the chat as we go through, and hopefully you're going to find this to be a useful session. So thank you very much for your time. I will return the screen back to you, Michael.
Thank you so much, Mark. And as always, a fantastic presentation. We do have one question in the chat. Is the January 1st, 2027 deadline final? I recently talked to a former CMS executive that estimated that enforcement will be deferred via enforcement discretion.
Let me say this. If you are a Medicaid agency, you can, under the rule, make a single 1-year extension request. So potentially Medicaid could push off to 2028. It's funny you say that, hearing that sort of rumor about could it be deferred. I was also at Dev Days last week, and one of the comments that was circulating was that maybe some of these elements of this rule may be accelerated. So maybe we'll see things like push to maybe implement the CRD piece earlier, or these bulk APIs, because they could potentially be of assistance to providers. So at the moment, I think everything is sort of pointing to CMS really staying the course at the moment. They're certainly doubling down on adoption of FHIR. So if you're not considering the use of FHIR, you really should be thinking about it. It's not going away, and things like digital HEDIS measures are going to double down on the use of FHIR.
Excellent. Thank you. Matthew, Tab, your questions. Mark, if you're available, we're going to move on to our next session, but feel free to respond to Matthew and Tab's questions through the chat.
Yeah, I'll be watching the chat.
Greatly appreciated. Now, excellent. Thank you so much. Now it's my pleasure to introduce our WEDI board chair-elect, the executive director with the Massachusetts Health Data Consortium, Denny Brennan, who will be moderating the remainder of this event.
Thank you, Michael, and thank you all for joining this WEDI session today. I think many of us have been asking the questions that participants such as those in this panel are going to start to answer, and we're very excited to learn from them. I'm very pleased to welcome Gregory LeGros from Athena Health, who is the executive director of the Payer Product Market Strategy. Hans Buitendijk, who is on the executive committee for HIMSS Electronic Health Record Association, and also a senior executive with Oracle Health, and Ryan Bohochik, who is the vice president of value-based care for Epic. Thank you all for joining us. We're very excited to have you here. I'm going to dive right in and start asking questions of each of you. And Greg, I'm going to start with you first. Describe in your words how Athena Health views the current CMS 57F rule. How are you going about the process of implementing it? And how are you communicating that rule to the providers and payers in your ecosystem?
Sure, thanks. And thanks for having me on the panel today. Very excited to be talking about electronic prior authorizations. Just in case anyone in the audience isn't aware, so Athena Health is a cloud-based ambulatory platform. We offer electronic health record, revenue cycle management, patient engagement tools. A big part of what Athena does, and really at a core, is to wick away work from our providers and let them to focus on what they should be doing, which is delivering clinical care. And obviously, I think most of us will agree that prior authorization is an extremely burdensome process that takes a lot of time away from the delivery of care. There was a 23 AMA survey that showed about 43 auths per physician per week. It takes about 12 hours to do. We also know that that also delays sometimes care that consumers should be getting. And that's because we've been reliant on these manual interventions, analog technology, all these inconsistent standards. So this was a problem that we really wanted to tackle, and we've been wanting to tackle for years. So actually, this was even before 0057 came about. we started working with Humana, a partner of ours, to implement an end-to-end electronic prior authorization process using the Da Vinci standards. And we actually stood that up, and it's been live since about July of 2023, so almost 2 years at this point. And in fairness, we did do this in a little bit of a measured way initially. So we have a service, it's a premium service where essentially any of our practices who don't want to take on the burden of prior authorization, we will actually do that on sort of their behalf. So we have agents who will actually facilitate the submission of those authorizations and collection of information. So we initially implemented the technology for those agents. And why we did this, and I think this is very important, is we wanted to make sure that we weren't burdensome our providers additionally with having suboptimal workflows, right? So we wanted to make sure that we could do this, we could test this, we could optimize it before extending it out into the clinician's sort of workflows. That's where we are today. So we are there, and then we are extending this out into our clinician's workflow. And I think the point that I want to make here is that we need to make sure that we focus on that when we are putting this fantastic capability in our clinicians' hands, that we're doing it in a way that's going to help them and not create additional sort of training burdens and whatnot. So that really means making sure it's integrated well within the sort of workflows of a practice. How we're communicating this. So, again, we're in the process now working with a couple large national payers where we're implementing this on a network-wide scale. So as we go through a part of our communications with our providers, we'll be letting them know that they can actually be transacting with these health plans in the next couple months for CRD, and then the full end-to-end sort of by the end of the year. So we have communication channels that we're using, but it has been received very, very positively, as you can imagine.
Well, thank you for that. That's very helpful. Hans, from your perspective, from the perspective of Oracle, and perhaps from the perspective of the EHRA, tell us about sort of how your organization is viewing this rule, how you are seeing the ways in which you can implement it, and your thoughts on how you communicate this to the providers in your community.
Sure, Denny, and I'll start with the EHRA and then just go to the Oracle perspective and touch a little bit on the aspect of how we are viewing the rule. I think generally there's support. There's need to be to make progress in EPA. Gregory provided some of the statistics around it. I think they're all evident. Something needs to happen to improve upon that, make it more efficient, make it more clear, faster, etc. So I think everybody will align on that. And we see that within the EHRA community, which for those that are not familiar with it on the call, it's about 30 EHR vendors, including the three of us who are on the call here, and a number of other ones, next gen, foothold technologies, and everything in between. It's a good representation, and they all look at it that way. And it's also always a question of how fast are the standards ready, et cetera. So when we look at the rules specifically, the questions have been, is CMS striking it right with advancing the use of standards? Without standards, we will not have consistent interoperability. But if they are adopted too quickly as firm, well, they're still in very early deployment, which we are at this point in time. Everybody is learning. Then we have to be careful. And so generally very supportive and appreciative of CMS striking the balance of recommending the Da Vinci guides, requiring FHIR or for as the basis. So in that context, everybody is running. Everybody's looking at that date. Not everybody is at the same spot as you will hear either today or otherwise. That it's on the spectrum. Some early start, other ones far ahead, already implemented. Between, from our perspective, and now I'm going to switch hats for a moment, is that we're in the midst of development of these capabilities across the range. Very specifically looking in the provider environment, how to integrate it with the workflow. It's essential. An element to add to what Gregory mentioned is that it's not only going to be a part of integrating with our own workflows where things happen, but we frequently are in environments where we have other HIT in the mix for the provider as well that are part of the prior auth workflow. So that's very much a point of attention for us as well, to coordinate those activities with those other sources as well. So that's a key area of focus. And we will learn more over time. specific availability otherwise, and we use our normal channels, reach out, education sessions, etc., to drive it forward. But we all eyes are on January 1, 2027, and there's a progression between now and then to ramp it up, and you'll see that among the wider EHR community.
Thank you very much, Hans. You think with 18 months to go, we're going to see incremental improvements, significant incremental improvements happening on almost a monthly basis. And how that communication happens with your customers is bound to be a very important thing. Ryan, turning to you and Epic, where are you with this rule? What are your particular perspectives on it, and how are you making this kind of API functionality available in terms of communication to your customers as well as rollout? How are you looking at that from the Epic point of view?
Yeah, I think first of all, just an acknowledgement on where collectively, Gregory and Hans and I, and probably many of you on this call, where we are now versus when this thing first got announced. Some of you probably were at the presentation at HIMSS. I think it was last year, potentially even 2 years in a row. Alex Muggy was at CMS, recently announced not going to be at CMS in the future. I think she'll be joining Hans and crew, but she gave a presentation on what the expectations were from CMS, because there were a number of questions that have really big implications, but we didn't really have all the clarity around. So if it was a national health plan that I work with, is it a single point of entry? How do we communicate? How do we handle things like delegates? So those of us that are in the weeds, I saw some questions in the chat. Matt Eisenberg, sort of is on the ground, understands the complexity that's there. And it's not as simple as saying, here's an API endpoint, you call it, everything else is taken care of. So Alex gave a presentation basically saying this is what the expectations are from CMS, from their perspective. And after she was done, there was a line, we ended up giving up trying to ask our questions because there was like 15 to 20 people that were waiting to ask her all these clarifying questions. I think the good news is, fast forward from that time until now, there is a good bit of clarity. And I think, to echo something Hans said, we've gone from this walk into more of a sprint now to get to a place where we'll have the requisite pieces in to be able to support this. So taking that where we've come as an industry, some excitement, maybe a little bit of trepidation, better clarity, to now where we are from the Epic standpoint. So we have, as you can imagine, been doing the work to make sure that all providers and health systems that choose to use Epic as their EHR will have the requisite support to do this work. I think most people know this, but what differentiates us from like Gregory's work at Athena, Epic is a federated deployment, meaning all the groups that use Epic have their own version of it. But what we want to make sure is that regardless of how people choose to do the configuration, they'll have these API, full support for, if we talk about auth specifically, CRD, DTR, and PAS, that will just be part of the Epic platform. If groups choose to use some other solution for this, that's great, but we want to make sure that everybody that uses Epic as their EHR and practice management system has it. So to cut to the chase, kind of long story short, we've been doing sort of pre-production versions, so some testing with some of the payers already. Think of it as like non-prod versions of this. We've got sandboxes available, so any payer, any provider can come test their version. Like, what would it look like with a representative payer? How this work if I'm a payer, getting it from a provider. So those are something we have publicly available for anyone that wants to test it. And then the full production, we'll really anticipate the endpoint of this will be in the February 26 version of Epic. So, seems like far away, or once upon a time seemed like far away, but about 6 or so months from now, anyone that uses Epic, they'd have these endpoints available. Certainly with any necessary updates happening along the way, but that would be we want to make sure that people have that year or so on ramp to do any other testing or working out the kinks before it's actually required to get things up and running in production. And then just like one other quick acknowledgement is like harkening back to something that Mark said. There's a ton of complexity that we've been working through with the health plans. I know Gregory does a little bit of this as well, and we'll get some of this and I think some of the other questions. But there's a lot of orchestration that's happening on their side that we need to work through with the delegates, with the litany of different systems that they have. So I think just an acknowledgement that some of the complexity is, it's just in the way that things have happened in the past, and not necessarily because there's not interest or excitement in getting to this this place where APIs can be the solution to do the prior auth work.
Well put. This is far more complex when we get closer to the ground. We think when we read policy, and the difference between the two is really where implementation happens. One of the aspects of policy has been the notion or the concept of certification by ONC, and there have been debates and perspectives on certification. Most recently, with Levitt Partners' Kill the Clipboard white paper, in which they talked about, focus on the APIs and the certification of the APIs rather than the electronic health records capabilities and functionality. Could you talk a little bit, and Hans, I'm going to start with you on this one. Could you talk a little bit about ONC certification and how you think it should happen, what should be included, and with that certification and the use of those APIs as an example, how would interoperability look like for many of the Oracle customers and members of EHRA? Are you looking at smart on fire integrations? Are you looking at direct integrations? Talk a little bit about API certification and how API functionality will be embedded in your technology.
We have quite a few questions in there, so
I know I did a great job of bundling them all together, so you might want to disaggregate that a bit.
Let's see how that goes. But just generally, if we start with the certification aspect of ONC, in HTI2 proposed rule, they suggested to require the use of, I think at that point in time it was version 2 or just published 2.1 for the respective guides and lock in on that. While CMS had a strong recommendation, everywhere you talk, and rightfully so, please use those ones, but have flexibility because we're learning. So that would allow for, if you then translate that into certification, to follow that and stay in sync, that would mean is that at a minimum, a functional certification requirement, you have to demonstrate support for prior auth API. That must be based on FHIR or 4. So that's the starting point. And with a strong recommendation, then they can do that in a variety of different ways that really enable you to and understand that's where you want to go. But if you veer from it, based on adjustments that have to be made, updates to the guide are continuously still happening as well, that you have the opportunity to adjust and not be stuck in a certification test that takes it literal. And that's for those not familiar with certification. It's a literal interpretation of the guide. So we're trying to follow the direction, skate where the puck is going to be, but not be stuck unnecessarily in certification testing that's too rigid in a format that has already been surpassed. So that's what we're trying to manage. So how can we get that across? So as long as ONC in its final rule, whenever it comes out, has that structure, where we can clearly see direction, alignment with CMS, and has that flexibility, so we don't get unnecessarily stuck in fixed tests that are not appropriate anymore or never were. In round 1 will be good, and then in round 2 or 3, shortly thereafter, now we've learned enough. We have demonstrated that it can scale. We have figured out the kinks a bit more. Ryan indicated we are working out on the kinks. Absolutely agreed. Once it's actually implemented, we find more kinks. Typically, how it happens. So we need to get that iteration in there before doing that. That's something that ONC has done before. That's not unusual. So from that perspective, that's the general mindset that you see in the community with Oracle specifically, others as well. Others believe that it needs to be locked in right now. We don't support that. When you then go into what kind of approach is everybody taking? We have to also keep in mind that on the provider side, there is the requirement, they shall support one successful transaction. We might come back to what a successful transaction is, but there is that need. So we have to do something. It's not like we need to have a certification rule per se to do something. Our providers are asking. We need to support. So you will see a mix. Is that you got a little bit of a glimpse out of that, in that depending on the EHR, depending on the provider environment, not just the EHR, but what revenue cycle are they using, because that plays a part of prior auth, the scaling system that they're using, that plays a part. Size Size of the organization also indicates how many more different systems they have and work that way. So that comes into as well. So you will see mixed approaches. Some will have it completely integrated in their environment integration, and that will work. They will not need a smart or a Fire-based app to sit on top of it. They'll take care of everything. Perfectly great way to go. Others will totally rely on those Fire-based apps and let them do it. And they will use CDS hooks and Fire US core-based Fire service to say, hey, I got the data, have a look at it, we can trigger you, and you run it. You may see in that environment as well as that based on where EHRs are, not necessarily certified or otherwise, they're going to use V2 messages as the trigger. They're going to use some proprietary capabilities. So you'll see a variety of ways in which that Fire-based app is going to be interacted with, but they in turn will use the Da Vinci guides to talk with the payer. And you'll see some mixes. If I'm not going to put the Oracle hat on for a little bit, you'll see that mixed kind of approach. We're going to integrate where we can and where we are there deeper into our workflows because we can. But we also need to be open to interacting with other parties there, either because they are the trigger or they need to be informed. They might be the middle person, or as Da Vinci calls it, the EPA coordinator, for a variety of reasons. So we have to be flexible and adjust to that. So you'll see that the combination of yes, Fire-based apps can sit on top, but will they always? Not necessarily. Depends on the level of integration that's needed. So I think you find a mixed bag.
Great.
Yeah, and
Thank
Danny,
you. Go ahead, Ryan.
I'll say maybe I'll jump in and give an example for the non-tech savvy audience. And I saw there was a question that came through about EHR certification versus API certification. And if I could maybe expand on something Hans said and give real world example. So if you think about having an EHR certified or a certified EHR, be it Athena, be it Epic, be it eClinicalWorks, pick your example there. The idea is that there's a certain set of requirements that we have to conform to as technology vendors to meet that level of certification, and then providers, when they use that EHR, by virtue of implementing it in the way that we build it, we'll meet those certain set of requirements. If you think about what historically is in an EHR, think of it as more core to taking care of a patient. So writing notes, placing orders, doing medication prescriptions. When you get into the world of prior auth, some of that stuff fits really nicely into a patient care venue. And where we really started in our work, really like even in the Da Vinci world, was we're going to use a technical thing here, but CDS hooks, which is if I place an order, I can go call out to someone to ask a question. And that was where we started to say, I can ask that question in the moment of the payer to say, is prior auth necessary? And sometimes you'll have enough information, we can get an answer back. It's great. We can move on our way, provide that patient care. Back to Mark's presentation, shrink the time it takes from identifying a need to getting the patient appointment scheduled. The reality is, oftentimes we might need to check at the time of scheduling. We might need to check at the time of, referring you from this primary care office to a specialist, and that specialist needs to then check on the prior auth requirements. And what we find is in the real world, it's not confined to things that happen in the traditional, quote unquote EHR. So the approach that we've taken from the Epic side, and as it relates to the part 2 of your question, is we'll have all the direct integration for these APIs in our software, but maybe 97% of the groups that we work with, where Epic is their EHR and practice management system, that's great. But what about the groups that use other practice management systems, or just anyone else that's out there that chooses to have an environment where it's not all one consolidated enterprise system? You just have to be mindful of that. So that comes into play in both the implications for this certification, and if it actually makes sense to have the EHR be the one coordinating these API calls and generating them, or if there's still a world where some of these Smart on Fire apps make sense. So again, the path that we've taken is incorporate it right into the tool set because it makes the most sense for our provider base, but it doesn't mean that that's the right fit for everyone. So that I get both, I think, some perspective on why there's this, we need to see things play out and how they'll actually become, production usage, and then also, how that, what the Epic approach has been, just given the way that we build our software.
Terrific. Thank you. Greg, from the Athena Health perspective, you your thoughts on certification
Sure.
writ large, and sort of how you see implementation manifesting itself within the Athena Health application.
Yeah, I mean, so, I agree with Hans. If we have some certification, we need some flexibility. But I would say, I don't think we need certification, right? So our providers have been clamoring for support and to streamline the sort of authorization process. If payers have these endpoints, I think we as EHRs are going to take advantage of that in support of our sort of clients. So I would suggest, perhaps we don't need it. We will activate on that. And that's certainly Athena's plan. So yeah, and we, as far as, we'll be integrating, sort of directly into workflows as much as possible. This will be an evolution, right? This is complicated stuff. We're not going to get 100% there, on the first swing. So it will sort of evolve in its, capabilities is my perspective. We were going to approach like using a Smart on Fire app for DTR initially, right? And that we just figure that's a good place to start, and given the readiness of the industry overall. But then we will migrate to CQL and actually being able to extract that data directly from the sort of EHR. So I do expect, again, this is going to be a journey. We're not going to be done January 1st, 27.
We only need to be done enough by January 1st, 2027. The
Correct.
minimum necessary requirements.
That's the real start of the journey.
That's when we start. Which kind of leads to the next question, which is, and Greg, I'll start with you here. When you talk to customers, especially health plan customers who are looking at this, are you seeing them looking at this integration of APIs, Fire APIs into their technologies, into their workflows as a compliance-driven initiative where they are looking to minimize their implementations to the extent necessary to meet compliance requirements? Or are they seeing this, there may be somewhere in the middle, obviously, or are they seeing this as a call for, a transformation of their architecture, the way in which their systems are organized to communicate not only with their providers, but with each other? What are your thoughts when you talk to payers about, their commitment to APIs and to this change? Are they regulatory minded only, or are they thinking about it more strategically?
Well, I'll start by saying, prior authorization is a decades-old problem. So I really, really hope we embrace this as an opportunity to be transformational. So that is my hope. Now, what is the reality? The reality is it's probably a mix, right? So certainly some of the clients that we've started to work with who are sort of first at the table are 100% committed to Fire APIs, are thinking about how to sort of re-architect the way that the prior authorization process works, and to gain the efficiencies that can be gained through these types of integrations. Is that universal across the payer market? I don't think so, right? And I think there are definitely some payers out there who just say, what do I need to do to be compliant with this by January 1st? But again, as was talked about earlier, this does have an opportunity to be transformational. If you think about the patient journey, and I've been here personally, and we all know people who have, where you're in the physician's office and there's some issue, they're like, well, we're going to need to get authorization for this. And you go home and they're waiting to call, you might follow up. Like, what is the experience being able to sit down and be like, oh, okay, we have the authorizations required. We obtain the authorization, stop at the front desk on your way out and we'll get you scheduled. Like, that is a very different sort of patient experience that, this can enable. So again, I don't think we're all there. I think hopefully we'll all get there, but it's still right now, I think, is a mix from the payer's perspective.
Hans, in your experience, both with EHRA and your work at Oracle, are you seeing your customers and their trading partners, do you see the same mix that Greg describes? Characterize whether you see more of a compliance, de minimis compliance kind of implementation versus a transformational one. Are you, where are you seeing, EHRA customers along these lines?
I think if we look at EPA specific APIs, I think you're going to see more of a progression, not to mean minimalist, but a progression of learning. So there are discussions. I think WEDI has had some discussions and a survey as well, should there be stages? Focus on CRD first, or focused on pass first, or take a progression, so not everything all at once. So I think it's more characterized by the progression and advancing on it, because it's very complex. That there is that interest to not move too fast, learn, and particularly if you look at it, we have some great news from the early implementations on the CRD side. We also hear is that when as everybody's implementing DTR and trying to understand what are the questions, how I'm going to get the answers, how can I automate the answer collection as best as possible so that I minimize the amount of user interaction. That's a hard nut to crack, to do that in a flow that works and that you get the right information. So I think that's where an area where people might say, well, I'm not going to move as fast. Plus, you get the questions from the provider, their HRIT vendors. How ready are the payers? Do they have all the templates? When you look out there, do they have all the questionnaires ready? Are they easy to understand and map into what I need to do? Not everybody's going to play with CQL at this point in time based on their complexities. So you add that all up, I think it's much more that people have how can I step through it with a solid first step, but not be required to take a full step. When you put in the terms API, it always gets confusing. And maybe I'm going to show my age in there, is that interoperability is effectively always around, in order to do interoperability and workflow support like this and other ones, I must have APIs. We can quibble about whether the API is version 2 based, NCPDP based, HL7 FHIR based, or whatever, but we need an API. We need to agree on format, transport, etc. That's what an API does. And generally there is where I think we have all agree is that we need to have well-specified standards-based APIs to move that forward. So EPA is a clear example of that. Without APIs, it doesn't work. I think the questions earlier and now around APIs and should ONC focus on APIs or not is much more about, is it more important for us collectively that tests and certification are around the ability to share data in an agreed to manner than that it is what the respective HIT, EHR, and image management system, whatever, what they actually do inside them. Focus on, if we want to get look at nationwide interop and interactions between providers and payers, it's about APIs. We want to talk consistently together with each other. So focus certification on that and take out everything else that doesn't have anything to do with that.
Thank you. Mark Scrimshire, you have a question or a comment?
Well, yeah, Danny, a comment. We obviously end up talking with a lot of payers, and I'm seeing a stratification in this question of compliance or business transformation. Amongst the smaller payers, typically seeing more of what do we have to do to tick the box. So really more of just a compliance play. They don't necessarily see how it's going to be transformative for them. And then amongst some of the larger payers, we're definitely seeing, yes, I'm going to tick the box for compliance, but that's really the first toe in the water. We're looking at what's it mean to actually go and apply this across the entire book of business. In fact, I was on a conversation this morning with payers about that, and there were a lot of ramifications for expanding this beyond the compliance requirement to a full book of business. A lot more questions come in. So I think they're going to take a step of let's get used to it with compliance, but then look to expand.
And if I may,
go ahead, Hans.
Add to that. I think it's a very important notion, and going also to the, is this a check the box? Is it transformative? Certainly hope that it's not a check the box, because this is a lot of work. It's a very complex environment. We're putting a lot of effort to make it work, and we all agree on the end goal of what we're trying to achieve here. It's a very costly, timely, etc. effort. So I don't think many will, in that sense, look at it as a check the box. We have done a couple of those already. We won't name examples where we have created things and they just sit on the shelf. And I see Greg and Ryan laugh as well. Yes, we can come up with an interesting list there. We better not have this one end up in the same shelf.
Ryan, from Epic and your perspective, how do you see this playing out?
Yeah, I mean, I truly am optimistic that it's more transformative as opposed to check the box. I was looking back, some of you are familiar with KLAS. They do, like consumer reports essentially for health IT. They put out a report around systems that payers were using for the first version of the patient access API. And they asked how many people actually had people using it, like patients or members using it. And majority, more than half the respondents didn't have a single use of it, which is, an outcome that no one wants. And not only is it wasted effort for us as developers and people that are in the healthcare community, but it's not getting to any kind of end goal that this thing set out to achieve. So I think nothing more to really state in terms of what I've heard from the payer community beyond what the other two gentlemen said. It is a gradient. I think even the groups that are looking at it as more of a compliance checkbox, the good news is I think that's like we need to be compliant by 2027, but looking ahead, we truly need to change the way that we do things, because it can't just be have someone hit an endpoint and then fall back to a portal or phone call or fax machine. That's not going to be, it's not going to fly in the future come 27. So yeah, I think right in line with what these guys have heard, but I have a healthy amount of optimism that the amount of effort that's been put into this means we're truly going to do things in a different way.
Great. This is hard work, and I know we're going to be talking about this when we meet with providers later this afternoon. But what are the roles of intermediaries here? And Ryan, I'd like to start with you on this. Many providers dread having multiple payer smart on fire apps opening up in their system in one format or another, or having different versions of integration, interoperability with different payers, different timetables, different expectations. Do you see a role for intermediaries in this? Do you see clearinghouses or QHINs or regional health information exchanges stepping in to reduce some of the complexity in this? Or do you see this? When I look at it and I look at the many-to-many problem we have, it's really hard to get to the end without having some aggregating influences in the middle. Can you talk a little bit about that?
Yeah, I mean, if you think of historically challenges with, we'll keep it prior auth, but it's sort of any kind of interoperability. There's I think of it as like three different buckets. There's how do I communicate electronically with someone? So how do I know that there's someone out there? There's an endpoint I can go find. Then there's what language does that person speak? So like how do I send information to them electronically? And then there's this aspect of, do I have translators, if we stick with the analogy, available that can translate the language I speak into the language that they speak? And I think what we've been talking about and what these regs from CMS codified was really the what language do they speak aspect of it. So we can have a common agreed upon language. We're all going to talk in FHIR. We have this set of FHIR APIs that we can all use, and we'll have conformity not only between the three of us representing the EHRs here, but with the language that the payers are going to speak. There's still historical issues 1 and 2 that I think the examples you gave still have a role in helping solve. The knowing how I talk to someone, maybe someday we get to the point where TEFCA, everyone joins it, and we're all, able to find these directory endpoints with one another. Not there yet for health plan use cases. So someone has to help me find, if I'm a health system, all these groups that I can connect to, if I know what language to speak. And then there's also this aspect of, I mentioned complexity and orchestration that has to happen on the payer side. So they may have, one of the groups we work with, national payer, they have 15 different systems. They all speak slightly different languages, and there's still an aspect of translating what I send as a health system to that payer into all these different systems or versions of that language that these systems speak. So a lot of Validity and others in the clearinghouse space, they're not just providing the connectivity between payers and providers, they're really being like the connectivity web on the payer side, and they know a status of this and this payer's system means this for us. And approval, they may qualify 3 different ways, but it means one thing for us. So I think at least in the immediate future, and even in 1/1/2027, there'll still be an important role for those groups to play in helping all of this actually, work in the real world.
Greg, what about from your perspective? I know we have only a few minutes left, but I wanted to get your take on this.
Yeah, no, I 100% agree with Ryan. This won't work unless we have these intermediaries. I mean, there'll be cases where we're going to connect direct, but that'll be with the large payers where the volume makes sense. But in order to get the hundreds of payers out there, yeah, there has to be intermediaries to help.
And Hans, from your perspective.
Generally, I would agree, and particularly picking up on Ryan's 3-4 different areas, is that where the directory, the ability to easily connect with the right health plan, where there needs to be assist, there needs to be an assist. But Michael Marchand puts in the chat, that's where the National Healthcare Directory might help out. That's where the TEFCA directory might help out, or it's just in other ways. It's very clear. Transitional services, analytic services, then you start to talk about, are you really an intermediary in the middle, or are you a value add to either the payer or the provider to help make the transition of the data less complicated on either side wherever you work? On the actual true middle between the two is, I think, the directory capabilities, finding who you are at, the language that we speak is going to be less of a challenge. But you still have all the other challenges we have on the provider side, many systems to talk to. On the payer side, what do you all need to do? Plenty of needs to help improve on the flow of the data overall.
Right, plenty of services to have on the network over time, but for the time being, we have intermediaries. Our time is up. I know we have a lot of questions that are in the chat. We will certainly keep those questions in mind and ask our panelists and others to provide answers if you are so inclined. But I am going to now, after thanking Ryan Bohochek, Hans Budendijk, and Gregory LeGros for your participation, I'm going to turn this over to Michael McNutt.
Thank you, Denny. And thank you once again to Greg, Hans, and Ryan for once again insightful discussion and panel. It's my pleasure now to introduce Dr. Steve Waldron, Da Vinci Project Clinical Advisory Council Vice President and Chief Medical Informatics Officer with the American Academy of Family Physicians, who will offer a little background information on accelerating HL7 Da Vinci Project adoption by providers. The Clinical Advisory Council Insights. Dr. Waldron, the floor is yours.
Thanks, Michael. Appreciate it. Thanks, WEDI, for having me to come talk a little bit about Da Vinci. I'm sure folks kind of have some sense of what Da Vinci is, but it is a collaboration between the payer community and the provider community and the tech community to try to drive forward payer to provider bi-directional interoperability through the development of implementation guides. I kind of have two hats, as Michael mentioned. My day job is I work as the Chief Medical Informatics Officer at the AAFP. And I can tell you that prior auth is an issue on the minds of many of our family docs and a significant burden for them, more so probably in the medication and kind of DME space, but all prior auths are kind of an issue. So I appreciate and just want to give a shout out to all the folks that are working on creating the standards and implementing them to decrease that burden. I heard a little bit to cover conversation too at the last call about if each individual payer created this great streamlined approach to prior auth, that still doesn't relieve the burden, because our docs and family medicine see on the majority of them have at least 7 to 10 providers, or excuse me, payers that they work with. So even if each individual ones of those were all streamlined, but they were different, that still is a significant amount of burden. So these national standards, I think, are really, really important. So I'll take off my AAFP hat and put on my hat as the co-chair of the Clinical Advisory Committee or Council at the Da Vinci Project. And what I wanted to do today in our kind of 15 minutes is to just give you a sense of what it is and why it is, and then talk to you about a project that we've been working on for the last several months that I was hopeful that we'd actually have the document published today, but we just finalized it today, and it'll get published sometime a little later this month. So Da Vinci has a lot of clinician input into the actual standards that they create and the implementation guides that they create. But Da Vinci wanted to make sure that the clinician voice, especially those from the front line, were really heard inside the organization, and wanted to formalize a process to make sure that that happened. And therefore, they created this Clinical Advisory Council, which is up to 12 clinicians. Currently, we have physicians, nurses, and pharmacists that are part of that committee. And the mission of that particular council is to provide strategic clinical insight and guidance to the Da Vinci Steering Committee. And those who are not familiar with the structure of Da Vinci, consider that kind of like a board of directors. And the program management office to ensure the program outputs stay aligned with the goals of reducing administrative burden, improving transparency, and simplifying access to and use of clinical data and workflows for providers and payers to satisfy regulatory requirements and improve patient outcomes. And what we've been able to do is we're able to provide a significant amount of input moving forward with Da Vinci. Actually, I and Ed Yu, who is the other co-chair as a family physician from Sutter Health, actually sit on the steering committee meetings. We don't have a vote, but we have the opportunity to weigh in on any of the conversations that the steering committee is having. And then the committee itself ends up meeting about once every other month now to address issues. So one of the projects that we worked on was we were looking at things in the fall of last year, is that the clinicians were not happy with the rate of adoption of the implementation guides, both from a piloting perspective, but more so from a production standpoint. And there was a kind of a flow through the conversation that we just had, talking about the need for standards, but standards in and of themselves are not sufficient to be able to get products that really work really well. So Dr. LaGrue talked about that from Athena's standpoint and some of the other things they did, and Ryan did the same thing from Epic and creating that kind of sandbox. So we wanted to be able to figure out how could we drive, or how could the nation drive the adoption of these implementation guides more quickly. So what we did was we brought in a couple of different provider organizations that have been trying to implement these IGs inside their organizations, and talked with them about what are their successes and what are their barriers to be able to drive the adoption of these inside their organization. And then subsequent to that, then we end up having a conversation with the steering committee and amongst the CAC and the CAC, I'm sorry, that's the Clinical Advisory Council. It's our kind of shorthand inside of Da Vinci. I'll try not to use it, but I fall into that, unfortunately. So our council said, all right, well, let's create a document that really articulates all the barriers that are out there relative to driving, rapid adoption of these implementation guides. And that created a 6-page document where 5.5 pages of that document is really focused on those specific barriers. And you'll see that document that's going to be published by Da Vinci this month. There'll be a blog post from Da Vinci as well. If you missed that, or you're saying like it's July and Steve said that was supposed to be out, it's not there, feel free to email me specifically and I'll make sure and get you a copy of that report. My email address is swaldron@aafp.org, and I'd be happy to make sure that you get a copy of that. But what I wanted to do in the next couple of minutes is just talk to some of the barriers that those provider organizations and clinicians identified that were really causing a challenge for them to really get to production level in regards to these IGs. The first and probably one of the big issues is limited resources, both from the standpoint of not having the funding needed, but also not having the technical competencies and staffing to be able to do that. A lot of these provider organizations are struggling just to support staffing on the clinical side, let alone adding in additional folks that understand this API economy that's being built inside of healthcare. And this is especially true of small and independent practices, which service a lot of our rural communities. So there's another concern there that even if we do see some rapid adoption, that we may end up creating a kind of digital divide for those organizations that don't have those resources. So there's a need to really identify how do we support those practices to either reduce the requirement in regards to resources to implement these IGs or implementation guides, or be able to create opportunities to create the resources that they need. And of course, I've already talked about the manual workflow, even if it is automated through a payer portal. But we did talk a little bit about that and some of the issues around that issue and the latency of claims and that type of stuff that was mentioned again in the last conversation. The next is organizational readiness. So a lot of healthcare provider organizations have many balls in the air. And this is just one of those things that they have to do. And sometimes, especially if they're not in a significant amount of value-based payment models, things like making sure that they are getting a class award, or that they're making sure that they're looking at optimizing other efficiencies inside their organization. They just don't have the opportunity to be able to work on projects that are needed to drive implementation of these if it's not turnkey for their organization. We also talked about kind of, community readiness. So there is the Trebuchet project that's really working on putting together, pilots, but they're still struggling to be able to get that from pilot to pre-production and be able to do enough pilots for all the IGs that DaVinci is producing. And then we need to be able to make sure that how that works, and how can we get from pilot to production as kind of flipping a switch, as opposed to, doing another project to get it into production. So we talked a little bit about that from a community readiness standpoint. We did talk about data governance and standards, and the question becomes: we know based on theory and initial conversations around these IGs that they are sufficient to implement, but they haven't. Some of them have not been really pressure tested in a wide scale adoption. And we know that there's going to be things outside of just the actual implementation guide that have to be standardized to make it work really well and to make it work efficiently. And then there's also the issues around trust around the data and who can have access. So, we have two implementation guides, the payer-directed exchange and the clinician-directed exchange, which are called PDEX and CDEX respectively inside DaVinci, that allow for that kind of bi-directional communication. So a payer could say like, oh, well, I have a patient that has been prescribed a medication for a proton pump inhibitor. Let's see if they've had a trial of an H2 blocker, because we don't see a claim in our pharmacy partner that there is one for that. So they could go in and query the EMR to try to find out, getting through reports or documents to find that as an example. And what we found is that that's just a challenge to be able to get implemented correctly. And the question becomes now, well, if you have access to that, what's the rules relative to that? Can you use that for payment and operations, and in addition to treatment, because you're allowed to underneath of HIPAA, but we don't want these type of data be able to be shared in a way that would maybe direct kind of networks, as an example, because then physicians will be less likely to be able to allow that type of access for payers. So that governance is really important. There's a huge section on EMRs, and I appreciate the work that was laid out by Oracle, Epic, and Athena to really drive toward these. But the clinicians and provider organizations are really dependent upon the EMR almost 100%. And if they're not be implemented in a way that not only is certified, but also is highly functional, that's going to require burden onside the practice if they're able to have the functionality at all. And then there was a lot of other things that we talked about, and we're about to kind of run out of time and make sure there's not any questions here in the last couple of minutes. But we did talk about education as something that's really, really important for the community to really work on, both from a provider standpoint, payer standpoint, vendor standpoint, policymaker standpoint. And we laid out a lot of those issues in the document. We did also talk about kind of the need for some additional measures and measurement and incentives. Again, if you drive toward value-based, some of our implementation guides are much more valuable to providers and payers to be implemented. And then lastly, there's a discussion around kind of advocacy that issues that are needed to do that. So from a DaVinci standpoint, the question becomes, we were built for creating implementation guides, but implementation guides are not sufficient to get to wide scale adoption of use cases inside of provider organizations and payer organizations. So what additional things like education should DaVinci do, and what are things that other organizations should do to really drive that? So hopefully you will take a look at that document when it comes out at the end of June, and it looks like we may have maybe 1 or 2 minutes for any questions that have come up. So let me look at chat, but if you have any questions, please put them in there. Happy to answer them.
Thank you, Dr. Waldron. Appreciate it. And yeah, for those on the chat, Leslie Amaros with DaVinci has shared some information in the chat that you're free to check out, some fantastic links as well. If there are any questions for Dr. Waldron, please enter them in the chat right now. We'll give you a couple of seconds to enter them. If not, please continue to enter those questions. And once we move on to our next panel, if Dr. Waldron is still on, he will be able to join. Oh, there is a question that popped up. Are providers open for flipping the script and having the payers adjudicate PA requests behind the scenes?
Yeah, so I would say the short answer to that is yes. From a provider standpoint, I would love to be able to say, like, I just do my work, my clinical work, and if I know I'm doing standards-based work from a clinical perspective, not from a technical perspective, that kind of authorization just happens in the background and I never see it. One thing I've always talked about too, and I think physicians would really love, is if you would actually move that to the front. So instead of it being a prior auth, that notion that I talked about of, it's not the best example, but it's the proton pump inhibitor and the H2 blocker. How about when I'm writing the script for the proton pump inhibitor, there's actually decision support there saying, hey, standard clinical procedure is to do a trial of an H2 blocker. Has the patient had an H2 blocker trial? Because I can't, the EMR can't find it in the record. So then again, it's real time, it's real clinically focused. So again, I think to answer your question, yes, I think the providers would be very open to that. With the caveat, again, I talked about is like, okay, well, what's the data trust issues? If you're having federated access into my EMR to answer those questions, there's going to be some guardrails around how you can use that data and access that data.
Excellent. Dr. Waldron, if you do have time, we'd welcome you to be a part of our next panel of providers. Just simply hang around, and when you wish to enter your thoughts, please use the raise hand function in chat.
Option.
Thank you.
Glad to. Thank you so much.
Allow me to hand it back over to Denny Brennan with the Massachusetts Health Data Consortium, who will be moderating our final panel, an all-star lineup of provider and provider types. Denny, floor is yours.
Thank you, Michael, and thank you, Dr. Waldron. That was a very interesting perspective, a compelling perspective from the provider side, especially the physician side. I'm delighted to talk with these people because I don't get to see them often enough and talk to them often enough. But we're all doing versions of the same thing in our respective communities, and it's great fun to get together and actually talk about what we're accomplishing and what we're struggling with. So let me briefly introduce our panel, which is, as I said, a distinguished one. We have Andrea Preisler and Heather McComas from the American Hospital Association and the American Medical Association, respectively. We have Anna Taylor from Multicare Connected Care, a longtime friend and colleague and participant in crime when it comes to all matters interoperability. We have Michael Marchand from Sutter Health, who is similarly a leader in our community from the provider side. And we have Samira Singh, who is the Director of Interoperability for Providence. So we have three major health systems that are making these advances. We also have Arna Meyer from the Albion Dental Technology, which is, I remember when the first JSON report came out about the state of healthcare information technology, and one of the primary gaps that the JSON report highlighted and that led to the Argonaut project and the like was the fact that dental was not integrated, was not a part of what we do. And the dental is a huge part of people's lives. It's a huge part of their healthcare. So we're delighted to welcome Arna to our discussion as well. So assuming I haven't missed anyone, and I don't think I have, we're going to plunge into a few questions. And we only have 45 minutes or 41 minutes left. So I'm going to segment the questions, as you guys have seen before, into groups rather than ask each of you to answer each question. We'll be here for the whole afternoon, which will be great, but we're not going to be expecting that of you. So let me start first with an association perspective. And Heather and Andrew, can you offer what, you've surveyed your communities, you've surveyed your members for the AMA and the AHA. And what are you learning from your members about the interoperability rule and about the automation of prior authorization, the access APIs, and what this means for individual physicians and hospitals and other facilities within your membership? Can you share a little bit of your thinking about that? Heather, I'll start with you first, and then I will go to Andrea.
Yeah, sure thing, Denny. And it's great to be here with everyone today to talk about this important topic. I will say that if we grabbed a couple physicians off the street, they probably wouldn't know what 0057 was. I know all of us in this audience, we talk in these numbers every day, all day, but practicing clinicians are very busy. They're taking care of patients. They're not into the weeds the way that you and I are on this topic. However, our survey data certainly consistently shows that prior authorization is a huge burden on physicians and on patients. We fielded our most recent survey of 1,000 practicing physicians in December of 2024. And once again, overwhelming majority of physicians said that prior authorization can delay patient care. And moreover, those delays are just not annoyances, they're not inconveniences, they lead to negative clinical outcomes, they lead to treatment and abandonment. And most shockingly, I think over a quarter of physicians, 29%, that said that prior authorization has led to a serious adverse event. So something like hospitalization or even up to death for a patient in their care. Once again, physicians are reporting that the volume of prior authorization is overwhelming. In this year's survey, physicians reported completing an average of 39 prior authorizations per physician per week. And 40% of physicians have staff who work exclusively on prior authorizations every day, all day. That's a lot of administrative costs in our system. And I think tying this back more specifically to the rule, we had some questions kind of asking about how physicians are currently conducting prior authorization. And right now in practice, I know, again, we're all kind of looking forward to the future of these APIs. Majority of physicians are still completing prior authorization using phone. And I think we can agree that it is wasteful and costly for all of us on the plan side, on the physician side, certainly. And another kind of alarming part of this is we asked about availability and access to electronic prior authorization for prescription drugs, which is a different standard than what we're talking about here today. It's an NCPDP EPA transaction that's kind of embedded with the e-prescribing. That's been around for a bit longer. It's mandated under the Part D program. Several states require it of state-regulated plans. And fewer than a quarter of our survey physicians have access to that technology right now in their EHRs. Now, maybe it's a question of they don't know to ask to get it turned on, or maybe it's not being proactively offered to them. But even for a more established technology, physicians don't have access to electronic prior authorization. So I think that's concerning, and I think it's part of the conversation today. How do we make sure that, as Dr. Waldron just said, that physicians can rely on their technology vendors to supply this technology and they have access to it? Because at the end of the day, there's not going to be very many physicians who can just build out the API themselves. They're relying on somebody else to furnish the technology for them. So I think that looking at what we're seeing already with prescription drug electronic prior auth, where it's something that should be available and physicians can't access that, we could see the same thing kind of reoccurring with the APIs, which is obviously nothing that any of us want to see moving forward. And I think it is a little bit of a lesson learned, is something we need to be watching in the next couple of years.
Thank you. Andrea, from the hospital perspective.
Sure, thanks so much. I will echo a lot of what Heather said. I think, you talk to hospitals at different levels of sophistication and stuff, and there are varying levels of education about the final rule. However, I think just about all providers that you speak with will recognize that the prior authorization process of today is in dire need of an overhaul. So they're very excited when they hear about this final rule. As of today, we have whole teams of individuals working around the clock to get prior authorizations approved for patients. That's not to say anything of, the appeals process as well, which is also very tiresome and cumbersome. And of course, a lot of this happens manually, as Heather said, it happens via phone, fax, and then of course the proprietary portals. So I think that it's safe to say that just about everyone on this call would probably agree that that's not a system that is working optimally, and that there are a lot of opportunities to make improvement. And we spoke earlier about, transformation versus check the box as exercise. And for providers, there is that MIPS attestation, right? But we sincerely hope that that's not all it is for providers. We really, really hope that there's a value proposition here, that providers will be very eager to leverage this technology and to come to the table. So I think we can all agree on all sides that we really want to avoid that kind of check the box exercise. And if the value proposition is there, providers, I think, are ready and eager to come to the table.
Thank you. Let's shift that now to that value proposition and to one of our representatives who has seen this at work. Anna Taylor from Multicare, in your work with Regents and Cambia, you've been a trailblazer here. You've been ahead of the market in moving to building the trust, building the use case, building the return on investment, and then starting to see the results. Could you share a bit about your experience, both the good, the bad, or I should say all the good, the bad, and the ugly, if you can? But we know there's a great deal for us to learn from it. So I'll leave that to you to decide which is which.
Thanks, Danny. I really appreciate that question. And I will always be transparent. There's no way of other being for me. It's just to say, here's how it is, because I think the more we share our experiences in truths, the more we're going to advance technology and innovation in healthcare. We hold some of this stuff very close to our chest. For example, even our decision making, our medical policies super close to our chest, thinking that that's a secret sauce to a better MLR. And it truly isn't. It's not going to advance the care we give our patients. It's not going to advance the way for which we can fund healthcare. It's only holding us back. So that's my one soapbox I'll get on before I get into prior auth, which is really a passion project for me too. We don't have any patient advocates on our panel today. This is a provider focused, but I just want to say, as a patient myself, I do think prior auth is necessary. If you've read The Price We Pay, we can see where there is nefarious activity in the system, and we have some bad actors that do need the cross checks to make this happen. So one of the things that often people ask of me is, well, don't providers want to just get rid of prior auth? Isn't that usually the stance? And it can be. Yes, some of our big associations agree that we should not have that. And how can we still prevent this nefarious action? So as an engineer, Multicare truly felt that we should try to solve this so we can do it in real time in order to get our decision making faster, get our patients what they need faster, get them to whatever other treatments they might need to ensure they can complete the medical policy. All of those things, if we could just make them happen automatically, means that now that's not a problem for me. Robots can do it. I can go back to my human treating a patient or analyzing what we need to do better in our clinical workflows to ensure our patients are on the right pathway to success. So all of this experience that we have is we implemented a prior authorization application into our EMR. So it invokes directly in the EMR. It's a button. They call it the magic button. It pops up the application in the workflow and says, hey, it pulls across any of the US CDI core APIs that are available within your EMR. So if that data is available in the regulated APIs, it will pull it into the form that the payers have for this type of technology. And then we input anything we need to input in there, because not everything that we need for prior auth is in US CDI core. In the current version, it will be in other versions. And then we go to the second part of the transaction, which is the actual medical policy matching and pulling the clinical data automatically into the medical policy. So this is where I feel like the big win comes, is we're only pulling the data necessary to match the medical policy. And providers get a win here to be better stewards of our patients' data, to be able to limit the amount of data we're sharing with our payers. We're only giving them minimum necessary for this operational transaction that we're sharing. So that was a win. Some of the other wins are productivity rates, and that was shared earlier. Thank you for sharing that. We were seeing a 233% increase in our productivity rates, and as we saw this across the board in different methodologies like bots that scrape things, our internal EMR's capabilities, a superhuman who can type really fast and has been doing this for 20 years. We compared all these things, and still the API really won out in its capability to scale, in its capability to give those people that seamless experience, and to be very good stewards of our data and our patients' data. So some of the ugly parts are you don't usually share a transaction with payers beyond money, beyond the X12s. So we had to change this narrative when we were together to talk through the different cultures that we were bringing together. So there were some teams that we had to create to make us successful. I would say the barriers, I would say that's a barrier and a win, because we figured out how to do it. And now that's a repeatable thing for us to develop relationships with payer that are shared operation relationships beyond negotiating rates. But it wasn't easy. It's a hard thing to do. And then lastly, I'll say, because we only did one payer and we didn't do everyone at once. So this is one of healthcare's, I think, hardest parts, is that because patient safety is like at the center of what we do, we strive for 100% accuracy. And that's what we want in everything we see. But as the world has changed and our capabilities in software development have changed, meaning we can do things faster, we can correct them faster, we see the errors faster, we have to stop thinking about being perfect on the first try when it has nothing to do with it's very far removed from patient safety. So for this, they were like, well, it's only one payer, Anna, it's not perfect, we're never going to keep using it, because it's not going to be our habit. Our habit is to go to the portals and put everything in. But it was so good that they kept using it, and they just continue to use it today. And they're like, how do we get more of those third parties in there? Matt Eisman asked a question earlier, and that's all a single sign-on process that the payer manages. So I would say, those are the overarching themes that we saw. I don't want to spend an hour on this, but I will pass it back to you, Denny. I hopefully answered those questions for you.
No, that was great. That was great. Thank you. And I think, building the trust beyond a financial relationship to one that recognizes that, both payers and providers have to solve this problem together and figure out how to establish trust in doing so is huge. I'm going to turn now to Samira and Mike and talk to you about your experience. Samira, you've mentioned in our discussions before that you haven't at Providence been able to adopt a prior authorization solution. Could you talk a bit about the hurdles and the roadblocks you've encountered to that particular goal?
Absolutely. And like others have said, thank you so much for having me today. And I will also say, I hate going after Anna, because you all are sitting here.
You're silly. You're so silly.
But you told this beautiful story about having a magic button and the impact that it has on your teams and the increase in productivity and all of these things that I think for all of us on this panel listening are saying, yes, 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 we need more of this. We need more scalable frameworks. We want to be able to build standards-based solutions. We want to be able to hit the ground running and so forth. But to your question, Danny, that's not the situation for most providers. And I'm happy to share Providence's story. So we started talking about prior authorization probably 2-3 years ago, when we had the first inklings that there would be something in mandates that would impact this. And so we've had our fair share of conversations with our payers, our vendor partners. We have an internal Tiger team that consists of leaders and clinical and operational teams across our different clinics. And so we've been in this space for a long time, right? We've been talking for a really long time. And in the spirit of honesty and partnership, because almost 200 of us on this call are partners, right? The reason why we haven't moved forward is due to some of the things that have been brought up previously. When it comes to a direct connection with a payer, a lot of our payers right now are not ready to engage, right? They're still in their market discovery work. They're still looking at the 4 APIs that they have to support by 2027 and directing their resources towards that. So we do not have very many payers in our markets who are ready to engage at this level. The other big thing is, and thank you so much all of our EHR partners who presented previously, is the question around what are EHRs going to do? When we think about the end-to-end solution consisting of, is an auth required? If so, what documentation and the response mechanism, which components are going to be covered within the EHR? How within the workflow? What is the trigger? Is it a Smart on Fire app? Is it something else? And so I think we just have a lot of those questions that, Ryan, thank you on the Epic side. You answered earlier today, but that's another sticking point, right? Do you go with a vendor? Do you support a Smart on Fire solution if there will be something that is more payer agnostic that's available through an EHR vendor? So questions around that. And so, the other thing I'd add here, so I think general market research readiness on the payer side, really understanding what our EHR vendor partner is going to do. And then the third thing is, I think a lot of providers, especially within our Tiger team, like the teams that are on the ground, they have a lot of questions as to how this will actually work. Because from a technology standpoint, we can say, well, yes, CRD, coverage requirements and discovery, will tell you if an authorization is required, right? And I think that's easy for me to say as somewhat of a technologist, someone who's spent a lot of time in this space. But when we have these conversations with people who are actually submitting the authorizations, you get responses like, well, yes, but when I, who am part of this Neurology Institute, submit an authorization for a service that is fairly new, I'll get a response back that says no auth required. But I know that's because the service is not covered. So if I move forward and I don't have all of my documentation in place, I'm going to get a denial that then I have to appeal. And that's going to take this entire process and make it a lot lengthier than it needs to be, right? So I think there are in general a lot of questions of, well, really, when you say this will tell me an auth is not required, what does that mean? And there's also, on the provider side, a lot of tribal knowledge, right? We talked about the digitization of policies, where they're housed, the teams on the payer side, and so forth. When I have conversations with some of our clinical teams, and I ask, oh, well, what's your reference for this, right? What document are you referencing? What website? Oftentimes what we hear back is, well, we have this document and we all know it. And then we ask questions. And then when there's a new person, my goodness, we have to start the training process all over again, right? It's this whole notion of tribal knowledge, which I think over time we'll have a lot of success in digitizing as information becomes more available. But that's really why I think from a provider perspective, there are still a lot of questions in the air as to what the best option is. And 18 months is not a long time. And, being part of a provider organization that does participate in MIPS, and that does want this to be something that is impactful and not just a check the box thing, I think a lot will happen over the next few months. And that's something that we're really excited for. Everything that's happened over the last 2 to 3 years, that was the pre-work. That's how we know we are ready to engage when everyone else is.
Thank you. That's very well put. Michael.
You want me to jump in? I mean, can I just say ditto?
Just jump right in. Yeah.
Great work, everybody, carrying all that water. But with the shovel on the back end to clean up, just a few quick comments for me. Part of the challenge here, at least as I've seen it in my experience working with Da Vinci and through multiple pilots with different payers and different methodologies, whether it's bulk or network fire through Trebuchet or direct connection with Centene. One of the things that I've experienced is that the provider side tends to be a little simpler because we're asking for something. And because we build our contracts super conservatively, we're going to ask for auth way more often than we do because we don't want to get in a circumstance where we have a denial because we didn't ask for auth. And one of the examples Samira suggested was a new service line, right? You're going to get a no auth required. So we need to have the tools and the APIs and the responses from those payers be a little more sophisticated. But I think the carrying the water of at least getting the electronic auth submitted, getting a response from that payer to say yes or no, but we need this additional documentation, and having the plumbing to support that. Because for as limited as a trust relationship as you can have between provider and payer organizations, given some of the contentious contractual negotiations that have happened here in California, I think that at the end of the day, if I had a patient that I needed a procedure authorized for, pretty much we're going to fax every record, we're going to email every record, we're going to do whatever they ask us to do to get the auth. And so why not make that administration, eliminate the administrative burden? We could use our buzzwords, put that on your bingo card. Eliminating the administrative burden of trying to fax records or email records and allowing the payer to come in, leverage the plumbing that's there, leverage the capability that exists to actually extract that information and provide real-time answers or real-time feedback is, hey, we were able to see this, but we need this. I think that that's where, as we become more sophisticated and advanced in this interoperability or this particular space, we'll be able to kind of narrow in on the 20% or 10% or wherever we're going to miss. But I think the advantage of that 80% or 50%, you pick a number. We all can pick a number to say, what might this speed up? But I can tell you just in it, kind of logically is we're going to give them whatever document they want. So the trust relationship in this particular singular request for auth kind of evaporates. And at that point, that plumbing, the ability for them to extract documentation to allow for that auth to happen in a real-time fashion or a near real-time fashion, or to push a CQL questionnaire back for the referral coordinator to respond to. I think all those things become reality as we turn this on. And my personal challenge has been just finding the right partners on the payer side that are ready to do this at scale. And that's where for me is having options is there's not a single solution. You have to be able to meet people where they are. But I think that as the technology narrows, as the requirements, the legal requirements and regulatory requirements kind of narrow in on pushing people into this pipe, it'll be, I'll say, easier for us to get there as a community, as opposed to today, which is I need to call Bill at Blue and Shirley at Aetna and somebody over here that I know to actually get this to move to the next step. Because today, just kind of in a community-wide standpoint, unless you're working with somebody with DaVinci or with some of the work groups that I participated in, those connections don't happen.
Thank you. Arna, you live in another universe, but it's in very many ways a universe that has the same challenges: affordability, access, interoperability, visibility into health plan policies and the like. There's so much in here that goes into whether or not a dental service will be covered and how patients and providers can know that as early in the process as possible. Could you share a little bit from your perspective, your vantage point, as you listen to these organizations talk about the CMS 57F rules, how you see this kind of transformation impacting your industry?
Absolutely. The dentistry, we do tend to be relegated to the side at times, and there's a huge push internationally, actually, to integrate dental records back into electronic health records, because the interoperability of our health data, it includes our mouth. Where dentistry is really struggling is we as providers don't always typically participate in federally funded programs like Medicare and Medicaid, and we don't have a high volume of MIPS participation over in dentistry. And that seems to be those are the levers that are being used to sort of help shift momentum into adoption of these standards and APIs. And so a lot of the adoption in dentistry at this point is voluntary, and it's been very slow going. Unlike peers in the medical space, we do have pretty good participation in prior auth on the EDI side. And so there's also a lack of understanding, a lack of education, an appetite to take on these hard problems, even though it would be immensely beneficial for care coordination and efficiency of payment, which is something we all want in the dental community. The other thing that we're seeing is this is really highlighting an access to care challenge that we have in dentistry. The American Association of Oral and Maxillofacial Surgeons have been really getting a lot of feedback from their members around concerns
participating in Medicare and Medicaid programs and actually providing care, because our software vendors, we still have a good portion of our software platforms, our practice management softwares and electronic health records that are server-based and aren't really building up to API standards. And so because we have these technological deficiencies on our side, we have providers who are participating worried that they may have to either disenroll or cease providing care to those patients that are in this cohort because of the technological issues that exist. And so it's quite alarming, especially for rural providers and for those providers that are working with these markets, because without the technological framework and the vendors coming to the table, and then the standards being developed to be able to transmit dental data, there's a huge gap for us. And so people are still going to be quite reliant on the old technology until we can bridge that gap. But I am seeing, like I said, I'm seeing international efforts to help harmonize standards between medicine and dentistry, which is really promising. But yeah, we've still got a long way to go.
Thank you. I appreciate that perspective, as I know our audience and our panelists do. I wanted to touch on a topic that was raised when we had the session with the EHR vendors. And that is, how do you scale this? Samira, when you look at your work, you're a very large health system. You do business with hundreds of health plans in all likelihood. I don't know what the numbers are specifically, but I'm just taking a wild guess. And how those health plans present information in your electronic health record is a bit of a quagmire or a bit of a hornet's nest at present. We can't have, several hundred different types of smart on fire apps popping up in the health record. Could you talk about, some of what you've learned and what you think might be helpful in your markets as to how to align payers around making the provider experience genuinely simpler rather than elevating the portal to, elevating into these smart on fire apps, the same problem we have with portals, where we have one-to-one correspondence with a health plan and not this kind of one-to-many health plans. Could you talk a little bit about that?
Yeah, absolutely happy to. And I'd like to take it back just one more step, if that's okay, because
Sure.
I think Dr. Waldron previously mentioned the importance of provider education in this space, right? And then it was mentioned on this call that when we talk about CMS 0057, although it sounds really cool, no one really in the clinical space, no one really cares or understands, right? And so I think that first step of, prior to answering your question, I think the first step of education in this space is extremely foundational, because when providers in particular hear, well, we're automating prior authorization, and it's going to be an end-to-end process, and you're going to know within 3 days for urgent services what the outcome is, and within a week for others, and so forth. There is this precedent that's set right away that this is going to be an end-to-end solution. It's plug and play, regardless of whether you're a primary care practice or a specialty clinic or anything else, it's all going to flow the same. And so I think when you create that picture and then you go into conversations with providers and you say, okay, well, actually, we have a Smart on Fire app, and actually, we're just in production with the CRD component right now, right? You're failing right away. And that is because that this illustration of how prior authorization is going to work by 2027 and the reality of where the market is at are not on par, right? And so I think first and foremost, we need to change the narrative, because if we take a step back and we say, well, to Anna's point, so many and to Marshawn's earlier, so many authorizations are actually not required. So much of the administrative burden that we currently have is requesting confirmation that this authorization really is not required. And if that piece is automated through CRD, then the question I think we should ask ourselves is it worth pursuing a CRD pilot with a payer or multiple payers if that is the only thing that you can pull to production right away? Absolutely, because your burden will reduce. And you know that scalability and iteration is going to be of the greatest importance, right? And so then, Denny, to your question of if there are so many other Smart on Fire apps, so many vendors in this space, so many different options, what do you do as a provider organization? And one of our leaders always talks about a wheel, and the spokes on the wheel, and how with every single use case, you cannot just have one. You need to be fluid enough to say that for this specific clinic or this specific service line or specialty, here's how we're going to do this. And for this other set of clinics, here's how we have to pivot a little bit. And so I think really level setting in that regard, and really, again, understanding what your EMR vendor is going to make available within, natively within the workflow, that's going to be the most important thing. I also think that this notion of, everybody's going to go live at one point and it's all going to be perfect, it's not realistic. And so I think as long as we can take a step back and say, how do we educate our partners in this space to truly understand what is possible? And then how do we highlight those big wins that we can have even without an end-to-end solution? And then how do we control the narrative as to what is actually available to us in the market? I feel like that will get us moving, and that'll get us away from focusing so much on the issues, and the issues being, right, things like, well, are we not digitizing the entire policy? Well, of course not. There's so many different specialties we have to account for. But does that mean that this entire thing is a failure if we're not doing everything at once? Absolutely not. We have so many opportunities to boost the administrative burden, to ensure that we have processes in place so that our AR days are positively impacted because we're not getting denials for authorizations, right? That, to Anna's point, even if it is for a smaller portion, we have the ability to automate which information is exchanged, so we're not doing manual chart pulls and sending things through manual methodology. So I know that doesn't necessarily fully answer your question around the multiple Smart on Fire apps, but I think that
No, but it answers it more broadly. It's a better, more foundational answer, and I think that's very well put. But Heather, in terms of your membership, and I'll ask Andrea you the same. When you hear Samira and Michael and Arna to a degree talking about education and awareness building, talking about sort of what constitutes success, given that we have regulations that have sort of de minimis requirements, and then we know that we're going to be on a longer term road, to mix my metaphors, we're going to be on a longer journey to get to where we need to get to. From your association's perspective, starting with you, Heather, what do you think about this in terms of educating your membership? Do you see this as a valuable direction? And I'm sure it may be one that you've already taken.
Yes, actually, Denny, very well-timed question. We just had our annual AMA House of Delegates meeting, and we had an educational session specifically about the rule and the prior auth APIs to try to get at least some of our physician members aware of the technology. And I will tell you, they are excited about it. I think it's important, and I know everyone in this forum knows about this. We talk about all this in the names of the IMP guides, right? But I try to talk about it and encourage others to talk about it. Like, imagine you're ordering something and the EHR pings your payer and it tells you right then and there if you need a prior auth, and then the payer sends you the data they need, and then you send the request and you get the answer back in your EHR. Just talk about it very simply in that way, and they are jazzed about it. The idea, they're not going to a portal and remembering passwords, et cetera, et cetera, et cetera, and they're not having to rekey in stuff. They're not on the phone. They're not faxing stuff. They are jazzed about that. I will say that one question that came up, and I'm sure it does not shock anyone, and others have alluded to this, it's like, what is this going to cost? And none of us really, it's going to depend. Obviously, that's a variable question, practice to practice and vendor to vendor, but that is a concern. And listening to everyone talk, I will say that I think this technology has so much promise if we implement this in the right way. I do have fears about us leaving folks behind because, and from my point of view, if we don't make this available across the country to all practice sizes in all geographic areas, we failed, frankly, because it's not just the clinicians who are practicing in a rural area or under-resourced area that we're hurting, they're going to be the ones that are still on the phone and faxing, right? We're hurting their patients too, right? Because they're not going to get the same faster treatment. So we're creating disparity in clinicians, but also in their patients. And that really gives me a stomach ache. So I think thinking about how are we going to make sure that the tentacles of this reach out and trickle down to the smallest practice size, physicians in all specialties, because otherwise we will not have really succeeded. And I do agree, it is going to be kind of in stages. And obviously the bigger systems and have more resources, and if you go up to a doctor there and you say 0057, they're like, yep, know what you're talking about. That's a different situation. But eventually we need to get to the point where the technology has gotten into these smaller practices. And it's, you know, they already are so financially challenged right now. If we're asking them to invest in something else, they're like, I can't, like literally, I can't pay my staff. And not to totally segue, but we saw last year during the Change Healthcare cyber attack, it was crisis for practices, and many of them are still digging out from underneath that, not getting those claims paid. So the idea of taking on a huge additional commitment in terms of financial resources, and also just as Steve Waldron mentioned too, it's the money for the technology, but also the staff training too. Initially, like people are gonna, I mean, Anna could probably talk to this a little, certainly more intelligently than I can, but I mean, the button is cool and easy, but people still need to learn how to use the button, I'm imagining, right? There still is some training. I think one thing we haven't talked about a whole lot, this is a little bit of a shift in workflow, right? We're moving stuff further up into the clinician's workflow. It's not, you know, there's going to be some, you know, clinician, physician involvement in things that they weren't involved in before. So there are going to be some like staff resourcing issues too. So again, being mindful that we need to do this in a way that everyone can access it, I think is really important. And I will stop being on my soapbox.
That was great. No, but that was great. That was great insight. Thank you. Andrea, from your perspective, from the hospital perspective.
Sure, thanks. Well, I don't know if I can say much more than Heather. However, I will just say that I think education is absolutely critical here. Wholeheartedly agree with everything Samira mentioned. And I think it's incumbent on all of us to provide that education. And I always call it the drumbeat. We have to just keep the drumbeat going. You know, like, should we do a webinar on 0057 for our members, you know, in a couple months to just keep the drumbeat going so that they know that this is coming in, you know, about 18 months, this enormous change is coming. So I think it's just so critical to keep educating, keep having forums like this. I will also say that, as Heather said, you know, there are varying levels of knowledge of this rule, and knowledge of systems. So what we've tried to do, at least in the very beginning, is sort of do like, this is how prior authorization works today. This is how we hope it works in the future with this new fantastic promising technology. So I think it's also keeping it a bit simple, at least in the beginning, as we kind of embark on this educational process, and take it from there.
Thank you. I'm going to direct my next question to Michael, Anna, and Samira. You know, what we don't know about how this will change things is a lot. And one area that has come up in WEDI conversations is, and we see this in our marketplace in Massachusetts, where some providers are thinking ahead and saying, well, if I know beforehand what's going to come back to me in a DTR, what documentation templates and rules I'm going to have to complete, before I submit the prior auth, I might be better at avoiding having to do the same work again and again. I might be able to use that DTR knowledge to start making sure that my electronic health record has what it needs where it needs to be. And you know, that I use that as one example of where people start thinking ahead and outside of, you know, CRD, DTR, PAS as a linear process, and begin to think about, well, I'm about to apply for a prior auth for this service. I'd like to know now what it is I have to have ready when I do it, and make sure that when I do submit a request for this service or any other to one plan or any other plan, I have a pretty good idea of what I'm going to have to reply with, and I'm going to know where it is. And I'll start with you, but could you talk a little bit about, you know, the ways in which you see, and that may not, this example I choose is just an example, but ways in which people are, that this whole process can be a learning process and people can start using the process to do things differently and maybe better than how it was originally envisioned. Can you talk a little bit about your experience on that, or your perspective?
I'm going to start with my perspective because my training is in human factors. So I'm a human factors engineer. I am always like, why doesn't it work that way already? That's like my brain. I'll walk into a bank or a grocery store and I'm like, oh, I see your problem here. Let me move the shelf for you. Okay. And that is just my bad habit. And I've been like that since I was born, says my mother. She's like, you're always tweaking something. I'm like, I know, but is it a better experience? Yes. So what I want to say here is that I shared this in the chat, in fact, is that when things work like a human might anticipate they work, it leads to greater things because you go beyond the ordinary. That, okay, if I put my debit card into the ATM, I'm going to expect to put a code in because I'm hoping it's secure. And then when I say I want $100, it's going to spit me out $100 or, 520s, whatever that ATM does. But actually, that's a funny design theory that you can think about. What do I spit out? What does a human want? So those are the things, how I'm looking at this. And prior authorization is something that, yes, couldn't you imagine a world like in the way I think, way I thought it worked in healthcare when I was a naive 27-year-old? I thought that prior auth was like the doctor sits in the office, they click an order, it goes boop, 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 boop in the computer universe, and then comes back and says, actually, we'd love for you to do 20 PT to see if PT will help you first. And then the doctor goes, okay, let's get you that referral to the PT and the imaging. And then before you have the neurology appointment, you're going to have all your results, and then we'll satisfy this medical policy to see if this is in fact medically necessary based on some sort of best practice science in healthcare. Well, that's not reality. That's like the vision of the future. But one thing that I mentioned previously is that if we don't start trying things in an agile mindset where we got to do one thing, okay, I trust it, I'm going to get more. You have to earn human trust in order to advance technology. It has to be what I call consumable by a human. And so if we can enable this process, prior authorization, to have the logic of the human brain involved with it, then it will be something that will transform healthcare. We will start to rethink how we do workflows. Maybe it is the physician that clicks the order button because every single thing is automated and they get an instant answer in 30 seconds or less. I mean, that would be an ideal world, especially for hospitals where they're seeing one of our specialists. We want it, that person has made the decision to have this surgery, and we want to say yes or no right there. We don't want them to wait 5 weeks. We don't want them to wait 2 weeks to get scheduled. So, and we don't want to schedule them and they say, sorry, you didn't get offed. So this is going to cost you so much money. So I think this type of technology has the potential to absolutely transform healthcare. In my presentations, I usually have the image of the US electrical grid and being able to transact in healthcare in using the internet and API technologies for which this prior authorization handshake does is the new electrical grid for healthcare. And if you think about all the innovations that were built off of electricity, this is the same potential for healthcare. But we all have to be wanting to transact this way. And there is significant investment in trying to scale this for each of us. So being able to incrementally get there and be incentivized to get there, I think will be a very important thing for the future. But it absolutely, Denny, has the potential to make us better, which is why I'm on this planet. Let's just leave it a little bit better than you found it.
Help make us
Wonderful.
better,
Michael.
Yeah.
Go ahead, Michael.
I think that the big thing, and again, just trying to walk in Anna's Hughes' shadow here, not as a human factors engineer, but as a petroleum transfer engineer, which was the fancy way to say I pumped gas one summer in college. But I put that on my resume and it sounded impressive. So, I think that the big thing here for a learning health system is to be able to enable the technologists to build technology to the human factors design that is easy to use. And I think that the webification or the Amazonification of these types of transactions where it's a WYSIWYG, you see what you get and it works the way you expect it to work. And we have empowered or enabled the technology to help solve some of these problems. And I think to Anna's scenario is if a doctor could push a button and say, Michael Marchant's going to get a hip replacement, pushes a button, and not only does it go and get the auth, pull the documentation that's required, made sure I did rehab and every cortisone shot, it also looks at the schedules and says, oh, we have a schedule available on this date, and actually puts you on the schedule. I think that's where the speed to market of going from seeing a physician for a condition and then trying to treat that condition and all of the associated hoops that we all have to jump through today by enabling the technology to actually access the information. And I put something in the chat. I actually said, where do we plug AI in? And I think that when I talk about AI, it doesn't mean like this magical box in the sky. It's like, to Anna's point, is today there are business rules inside of electronic health records that prompt physician behavior because of information in the health system, right? So as we build these pipes to do these transactions, we'll build intelligent rules to say, if X, then Y, then Z, and you can actually automate, robotic process automation. Again, everybody uses AI for everything. I like to call the technology what it is. So RPA is something that's well-versed and well-believed and works really well. And as we feed these datas and these workflows into these streams, we can leverage that same type of technology for that automation. And to the point about, the digital divide and leaving folks behind, I think those things can be replicated and can be federated and then made available to the have-nots in a way that we haven't been able to before, again, leveraging the web and the technology that is the underpinnings of all of what we're working on.
Thank you very much for that. We are at 21 minutes past the hour. Michael, I'm going to check in with you. Are we up against the clock or do we have a few more minutes?
Feel free, a few more minutes wouldn't hurt.
Okay, I want to build on this theme of sort of imagination, Imagineering, if you will, that Anna has got started with us, and I think it's I think the electrical grid analogy is a great one. We're building a new network. We're building an entirely new health data network, and we're cobbling it together from disparate pieces, but we have constituents, people, institutions who are more or less able to participate, access that grid. And Samira, based on some of the things that you've heard today and some of the, conversation we've had, if you were to sort of put on that Imagineering hat and say, I would like one thing to happen transformationally or a big step in my process with this, what would that step be? What would be your next major step to get to where you want to go?
So I will first say I'm disappointed because the last question I didn't get to answer, and I just wanted to say ditto. I get really excited.
Okay,
No, I'm just kidding.
I wasn't expecting you to say that's baloney. I completely disagree with that. I was hoping that you would agree with that, and we would take it a step further with you.
Yeah, Marchant, Anna, and I have this whole thing of where we want to say ditto to what other people have said. But I will also say that I'm probably the worst Imagineer, and that's a horrible thing being in a product pillar. But to be very realistic in this case, when I think about prior authorization and I think about what we've done thus far and the uncertainty around adoption on both sides, right? And maybe I should go to Disneyland Marchant, but the one thing that I would like to see happen right away is really just that adoption of CRD, right? This is setting the bar really low, right? Because if we're talking about administrative burden and having to go out to all these different portals and the percentage of procedures that actually do not require an authorization and so forth, that first piece for us would be a big win across the board. EHR native, provider or payer agnostic CRD app. We know that the endpoint connectivity factor is going to be an issue, but getting that fixed, I feel like it's just going to make a lot of people's lives easier. The second piece, because okay, maybe I do have a little bit of imagination. The second piece.
So it just takes a little while to get activated, but it's coming.
Absolutely. That second piece is, I think a lot of providers in general have questions around policies, right? You get a response back and it says auth required, submit this documentation. Oftentimes it feels like you don't understand why you're submitting documentation. And to Anna's point about minimum necessary and Marshawn's point about going overboard and just giving everything away, it feels like that initial reaction is, well, I'm just going to give you everything. And you are going to be the all-knowing party that's going to make the determination. And this is going to get my auth approved. And I don't think that's the right way to go. I know we can't talk about companies, but I saw this demo from a company a few days ago. And when the response in the second piece of yes, an auth is required, here's why, there was a digital component that said, here's the policy, here's when it went into effect, here's how we use this documentation, here's what's going to happen with it, right? That open sharing explanation component, I think, is absolutely major. And if we can build that level of trust between payers and providers to say, yes, an auth is required, and here's why, and here's what it means, and here's how we're using the data that you can send us, I think that's what we're all aspiring to, right? And I know that we're talking about prior authorization, but I would not be me if I didn't talk about value-based care as well, because I just love it so much. The data that we shared, Mark Scrimshire, I think you did a great job earlier where you said, yeah, there are these 4 APIs. Yes, prior authorization is one of them, but there's this big emphasis on bulk, and there's another big emphasis on, patient access, provider access, peer-to-payer, and so forth. All of this is really laying the foundation for all of that to work, right? The definition of what minimum necessary is for specific use case should be universal across those APIs, right? We should be able to take what we learn in prior auth implementation, the way that we share the digital policies, the way that we share clinical data, the way that we respond to a CDEX request if additional information is required, and apply it to everything else. Like, this is the floor. Let's meet all of our mandates, and then let's talk about where's the ROI? What other use cases can we scale this to? What profiles do we need to adhere to, and so forth? Because I love the idea of this being the electrical grid of healthcare, right? We're going to do all these other things. So there I go, Imagineering. Let's start with CRD. Let's include the policies. Let's get to the point where we, as payer providers, vendors, can meet the standards. And then let's talk about what do we really need to do to serve our patients better, to build, bidirectional scalable ecosystems where data liquidity is no longer an issue, right? It's something that is common with privacy and security and so forth in place. So let's just jump to 10 years, Denny, and have this conversation, and we're all going to be much happier. But it'll take some time, but we're all Imagineers, I guess.
Arnie, you're nodding your head. And so what is going through your mind at this moment?
Well, I have the privilege of coming from a system that did work into a system that doesn't work as well. And so I also I have these unrelenting standards about how easy data exchange can be, having come from Australia and seeing it work in Canada too. I know we got most of the way without talking about AI, but there is a huge promise in that, and I'm seeing it. Dentistry is easier when it comes to prior authorization. We don't have nearly as complex workflows. And as a result, I've been able to work on some really fun things around recognizing the supporting documentation, using RPA and computer vision, because the odontograms are really easy to classify parts, like which teeth are in the mouth, and getting those to justify and attach, and actually automating that process. And to Samira's point, the return on investment in this automation is huge. And I meet with executives of healthcare systems and talk about the work that we're doing in this regard. And that's actually how I'm able to move the needle, is just to point to the economic impact to the bottom line when we can actually process and remove a bunch of this manual process around getting the information into payer portals and moving it across. Now, again, I give the caveat, I'm still doing this in EDI world. We're not at API world yet here in dentistry, but gosh, I want to be. Because instead of a couple of days of interchange, I'd be my whole goal is 15 seconds or less. Like that's my benchmark. I'd love to have answers. And then I'm learning through these conversations where there's some opportunity for me to sort of go out and get fancy around once we get that authorization back, continuing the workflow. And then the other opportunity I see is then integrating dental care back into medicine, because a lot of what we're talking about when it comes to dentistry will be more complex cases that do require coordination of care that may be delivered in ambulatory and hospital systems. But because we're in disparate records, a lot of times we may need, if we're not accessing the electronic health record and we need to get information, this is bigger than just prior auth, is basically what I'm nodding at. Like, this is the foundation for the rest of interoperability, because once we start getting payers in, once we start getting providers in, and once we start setting this expectation with patients and being able to communicate with them that this is happening, it'll gain the momentum to continue building out to make everything else as efficient. And so I guess I do have quite the Imagineer hat on. I see the harmonization of all the different specialties, and I see bigger than just prior auth. I see all of the transactions and all of the information we need to move around happening as we go down this path.
Well, that's a wonderful note for us to finish on. I want to thank Michael Marchant, Andrea Chrysler, Heather McComas, Arna Meyer, Anna Taylor, and Samir Singh. I want to thank all of you. This is a wonderful conversation. We could start talking about AI, but we would be here till tomorrow. So we will wrap ourselves up there. And again, thank you very much for your participation today. And Michael, I will turn it back to you.
Thank you, as always, Denny, and thank you to this fantastic all-star roster of panelists. For those who hung with us this entire time, gold medal to you. Thank you very much. We have upcoming events, a lot of them focused on 0057. June 18th, how an interoperable server and prior authorization solution work together for CMS 0057 compliance, sponsored by Utility Health and Onyx. Then we go into artificial intelligence. It was just mentioned. Smarter Care, how healthcare providers are harnessing AI for efficiency and impact, June 20th. June 26th, we go back to 0057, the road to 0057F readiness, digitizing prior authorization policies for health plans, sponsored by Cohere Health. Additionally, in July, we look at our Securing Healthcare Federal Insights on Today's Cyber Threat Landscape with speakers from the FBI, NIST, CISA, and more. And then, of course, to close out the summer, August 5th through the 6th, our annual Summer Forum in Chicago, Illinois, and Zoom. It's a hybrid event. Prior authorization and X12's 8060 transactions will be the main focus of those 2 days. On behalf of everyone here at WEDI, thank you very much. For everyone who registered, you will receive the slides as well as the recording post-event. Thank you very much. Enjoy the rest of your day.